tried to access via the right and I had to go in via the left. Thank you to Cook and the conference organisers for the opportunity to present this talk and share my thoughts. It's a broad overview of my thoughts about how to achieve success in the treatment of thoracic aortic pathology, and some of it will be fairly basic for the more experienced consultants, but it's good to go over it. And the interesting point for me in writing this talk was that the backbone of the talk is actually a talk that I've been giving over the last decade, and it's interesting to see how some things have stayed the same and how some things have progressed with incremental advances in technology and knowledge. So my general considerations for achieving success with TEVAR is to consider a number of different variables, including patient factors, pathology being treated, the imaging requirements, the sealing zone, and in particular sealing zone has become an area of significant advances. The sizing of the device, the access being used, length of coverage issues, and I've got a couple of interesting points about that, spinal cord protection and device selection. In regards to the patient, some of the key factors to take from history before embarking on TEVAR is firstly, of course, to look out for the internal mammary graft on the left side, whether or not the patient's had a previous abdominal aortic aneurysm repair and the implications of a spinal cord ischemia, the presence of an aortic valve and the implication that might have for guide-wise in the proximal ascending aorta, whether or not the patient's had peripheral arterial disease and surgery and the significance for introduction of a device, the presence of chronic renal impairment, and whether or not the patient's on significant anticoagulation therapy and the implications that might have for introduction of a spinal drain. So pathology clearly has a big part to play in how we do the procedures and what we choose to do. And for aneurysm, it's fairly basic. We're trying to achieve a seal both proximal and distal to the disease process. Dissection starts to become quite complicated because in particular distally it can be hard to work out what to do with distal sealing. And we just heard a nice talk about how to use the petticoat technique for that problem. We've heard some nice talks this morning already about penetrating aortic ulcer and intramural hematoma, and then coarctation and trauma are other pathological problems that we deal with in the thoracic aorta. So here's just an example of a patient with a significant coarctation causing cardiac dysfunction, treated with left carotid to subclavian bypass and TX2 TEVAR with a nice result, just showing how that operation can be used for this particular type of pathology. Here's a patient with a 64-year-old woman with acute type B dissection and significant ongoing hypertension, pain and instability, treated with TEVAR and the petticoat technique, achieving thoracic false lumen thrombosis and visceral artery patency with no spinal cord injury, which is one of the few times that I've used that petticoat technique, but used it successfully. And a different type of pathological process here, we've got a lady who's had a type B dissection 8 months previously and has had rapid aneurysmal degeneration of the distal aortic arch and proximal descending thoracic aorta, looking for a proximal sealing zone, constructed a carotid subclavian bypass, and then stented with a TX2 device and an Amplatz plug insertion. So, these are just fairly basic examples of the different pathology that we're treating and the different adaptation of technique to treat that pathology. Imaging, of course, and this really hasn't changed over the last decade. We're looking at CT angiography, perhaps used in conjunction with different software programs to interpret the imaging differently, but the basic requirement is a CT angiogram, and also, in particular, going right up to the circle of Willis so that we know at least have some idea about the contribution of vertebral artery supply to cerebral perfusion, and then the other adjuncts being angiography, duplex, and Iverson toe. So sealing zone, my approach to the sealing zone is to try to achieve 2 centimetres of good sealing zone proximally.